I was going to make a joke about an SDA joke, but I feel a lot of people are going to be attacked. So grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Mosesjrk. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at neurocysticercosis. If you haven't yet subscribed to the channel, what are you waiting for? Hit the subscribe button, hit the bell notification icon so you can be receiving notifications of such amazing content every time I post. If you haven't yet followed our WhatsApp channel, we are currently at 562 followers at the time of posting this particular video, so scan the QR code. You will be receiving daily WhatsApp updates on the channel that will be helpful for you in your practice, or maybe just some interesting things that I have come across in my practice, or things that I'm going to come across in my practice. I may not be able to post videos every single day, as you've noticed, because we've been having really nasty power cuts, but definitely I will be posting updates in the WhatsApp channel. So please make sure you head over there. I will leave a pinned comment on the comment section below. So before we dive into the case and jump right in, there is one particular case of a woman that was 65 years old that came into our emergency department with some focal neurologic deficit. She had hypertension that was rather uncontrolled. She had a history of having a sudden fall, and then initially we had some concerns that this woman had a CVA, had a cerebrovascular accident or a stroke. So we did a CT scan, and this is what we actually saw from this woman. So I'll play the video and just have a look at the CT. I won't say anything at this particular point. I just want you to be able to pick up these things before we actually go into the lecture. And she actually had quite extensive disease, as you can see. Okay, I'll play the video once again. Once it finishes, I'll play the video once again. Have a look. You can pause the video wherever you want to pause the video to look at what you are witnessing on this particular video. This is, of course, a real-life patient that we saw. Okay, great. So getting into the details, remember that neurocysticercosis is going to be pretty much caused by a cystode, which is a type of helminth. And it's going to be, there are many different types of cystodes, but two important ones that you need to know. One that is affecting pork, which we call the pork tapeworm, and the other one that is affecting cows, which is known as the beef tapeworm. The pork tapeworm is known as Tinea solium, whilst the beef tapeworm is known as Tinea saginatum. The pork tapeworm is the one that's going to be causing you neurological cysticercosis, which is why I wanted to make the SDA joke, because SDAs don't eat pork. Then the Tinea saginatum is going to be the beef tapeworm. This one is not going to be associated with neurocysticercosis. It's just going to be associated with tinniasis infections in humans. And remember that in humans, this cystode is actually the humans are the intermediate host for this cystode. So generally, cysticercosis is quite a common cause of seizures, especially in endemic areas. And we get those low-income areas, low-income countries where they keep a lot of pigs, things like in Central and South America, in Asia, in Africa. And generally, the propagation of this disease is going to be attributed to poor sanitation and hygiene. There is no gender or racial predilection, and most patients that actually are symptomatic are going to be between the ages of 15 to 40 years. And infections sometimes could occur in the background of extraintestinal disease, including the neurocysticercosis that we're going to be talking about. That's going to be resulting from someone ingesting food or even water that is contaminated with human excrements that have the tinea sodium eggs. This is a bit different from the life cycle that I'm going to talk about, where someone ingests the undercooked meat and they eat the larval cysts that are found in the muscles of the meat because the meat is undercooked and those cysts did not get killed. Then they mature into the adult intestinal tapeworm. So that's a bit different compared to that particular life cycle. So here's the life cycle of tinea sodium. I want us to focus here at the beginning here. So this would be a person that ingests this undercooked pork or that meat that is going to be consisting of the cysts, the cyst larvae. So remember, once this has been ingested, these cysts are going to be found in the muscles of this animal. So for example, in pigs. So this is now going to enter into your system. Then once it enters into your system and passes through your digestive system, the cyst itself is going to evaginate and then it's going to attach itself to the small intestine. So you have the head there, which has an attachment part that's known as a scolex, which is going to attach itself to your intestines. So once now you have this scolex attaching itself to the intestines, it's going to mature into this adult worm. And this takes roughly about 2 months for it to happen. And then once these adult worms have now been attached, and remember, this will be sucking all your nutrients, sucking all your blood. It starts now to produce these other smaller segments that have eggs in them, that are going to be bearing eggs. These are known as proglottids. So once these proglottids are actually released, they're going to release their eggs, and these eggs can sometimes detach, or the proglottids themselves can sometimes detach, and they can be passed through the anus, or they can sometimes migrate. The tapeworm itself or the proglottid can sometimes migrate to the anus. Sometimes this proglottid, sometimes even the eggs, sometimes even both of them are going to be passed on from the human, and then they're going to be passed on into the feces. Now remember that once they're passed into the feces, sometimes the pig can now start to ingest these eggs, because pigs like eating everything. They ingest the eggs and they ingest these the detached proglottids, and then these sometimes can infect the pigs and essentially also result in cysts in the muscles of the pig, completing the cycle. Then sometimes the people can get infected by ingesting the eggs or the egg-bearing proglottids, and then sometimes these ones are going to develop into these spheres, which are going to be invading the walls of the intestines, and sometimes they'll spread to other different organs, including the brain. So these oncospheres can sometimes get into the bloodstream, and then they go and attach themselves to the striated muscle. They can go attach themselves to the brain. They can attach themselves to the liver, and sometimes even other organs. That's where you're going to develop the cysticercosis as the disease. If it's in the brain and in the spinal cord, you call that as neurological cysticercosis. Remember that these viable cysticerci now that are going to be found in these different organs, whenever they now live their life, they may sometimes have minimal, even no tissue reaction. The problem comes in when they begin to die. So when these cysts die, especially in the central nervous system, in the eye, and in the spinal cord, they're going to release antigens. And remember, when these antigens are released, it will stimulate the immune system. And when the immune system has been stimulated and you get this intense tissue response, this is going to be causing the edema. It's going to be causing a lot of dangerous side effects, which means that it's not all patients that have neurological cysticercosis that we're actually going to treat. There are some patients that we actually don't even give antihelminthic agents. And remember that these symptoms often do not appear maybe after years of the infection. And if it's affecting the brain in terms of the neurological cysticercosis, most of your symptoms are going to arise because of the mass effect, because of the inflammation, and all this is attributed to the dying off and the degeneration of these cysticerci and them releasing their antigens. So it's actually believed that if you get an adult tapeworm that's present in the intestines, sometimes even the gravid proglottids can sometimes move backwards in a retrograde fashion, and they can move from the intestine to the stomach, where they are going to form these oncospheres that get into the bloodstream, and then once they migrate to the subcutaneous tissue, the muscles, the other organs like the liver, they can also migrate to the central nervous system. That's another way in which you can get the neurological cysticercosis. But the adult tapeworm itself is going to be staying in the bowel for many years, and it can reach up to 2 to 8 meters actually in length, and it will produce about 1,000 proglottids, and each of them will be approximately 50,000 eggs. So the clinical features of this condition largely depend on the location where you're having these lesions, the number of these lesions that you're going to be having. So generally, there may be a period in time from when the person got the infection to when the symptoms actually came about 1 to 30 years. So they may present with seizures, which is one of the most common presentation. And remember that in endemic areas, it's a common cause of seizures in young adults, especially it would be in the background of those adults that take alcohol and eat pork. They could present with headaches, signs of increased intracranial pressure, hydrocephalus, focal neurologic deficits. You may have altered mental state, aseptic meningitis, and Brun's syndrome, which is often caused by cysticerci in the third and the fourth ventricle. It could also affect the spinal cord, the muscles, the subcutaneous tissue, the eyes, and in some cases, the adult worms just cause this mild GI symptoms. So you may sometimes even see the proglottids in the stool. But generally, substantial secondary immunity is going to be developed after the larval infection. In terms of the diagnosis, remember a CT and MRI brain imaging is very important in diagnosis and follow-up of the condition. We can also perform some serological testing for these particular patients. So remember, we may do some CSF serology. That's quite important, especially if they have intraventricular and subarachnoid infection. Sometimes we may perform a serum and even CSF immunoblot assay, which is quite highly specific and sensitive, especially if someone has extensive disease, more than 2 CNS lesions that are present. And the sensitivity is actually much lower if they just have one cyst that is present. Sometimes the antibody-based assays, such as the immunoblot, cannot really tell you whether someone has active disease or they have inactive disease. Sometimes only neuroimaging can actually tell you this. So the monoclonal antibody-based antigen detection assays are going to be used quite extensively in Europe, and the antigen detection assays actually are going to have a much higher sensitivity for the subarachnoid and ventricular neurocysticercosis compared to those cysts that are found in the parenchyma of the brain. Then the sensitivity of these antigen detection is actually improved when the CSF rather than serum is actually used, but you do have some false negatives when they have the parenchymal disease, like I said. When you do a microscopic examination of the stool for ova and proglottids, you may sometimes actually do this if they have intestinal infection. You'll see those adult Tinea solium worms, and this is often going to give you the diagnosis on the stool samples, and you can sometimes see the ova and the proglottids. So the ova are actually indistinguishable from those that we see with Tinea saginatum and Tinea asiatica, but generally the eggs are present in less than 50% of the stool samples from patients that do have cysticercosis. In terms of the brain imaging, remember we often make a diagnosis using our CT or MRI. This is done to evaluate neurologic symptoms. Like I said with our other patient that came in for suspected features of a stroke, and turns out they had a neurologic cysticercosis. So generally, imaging and your findings are going to depend on the location and the stage of the infection. I'll give you the different stages radiologically in the next slide. But you may see solid nodules, you may see the cysticerci, you may see the calcified cysts, you may see ring-enhancing lesions, you may have a hydrocephalus, an obstructive hydrocephalus. And depending on where they are, they may either be intraaxial or extraaxial, but most commonly you're going to see them in the parenchyma of the brain, as I showed you much earlier on. They can be seen in the subarachnoid space, over the cerebral hemisphere, as these ones tend to be quite large. They may be seen in the ventricles. They may sometimes even be seen in the spinal cord. Sometimes these are associated with concomitant intracranial involvement. According to the pathological stages, or the Escobar's pathological stages, you can divide them into 4 main stages. So there's a mnemonic that you can actually use. Vegans can't get neurocysticercosis, which is ironic. So vegan for vesicular stage, can't for colloidal vesicular stage, get for granular nodular stage, and the neurocysticercosis for the nodular calcified stage. So in your vesicular stage, you get these viable parasites. They'll have an intact membrane and there was no reaction. So you're not going to be having any perilesional edema that's going to be there. In terms of the colloid vesicular stage, your parasite dies within about 4 to 5 years if they haven't been treated, or earlier if they have been treated. Then the cyst fluid is going to become turbid and the membrane is going to become leaky, so there'll be some surrounding edema around the cyst. So this is the most symptomatic stage. Then the edema is going to decrease as the cysts begin to retract, and then eventually the enhancement may still persist at this stage, and then calcium will deposit there. This is the end stage where there will be a calcified cystic remnant. There won't be any edema. So those are the 4 main stages. So generally in the vesicular stage, you're going to see your cyst with a dot. Usually the dot is eccentrically placed, and the fluid inside this cyst has a similar density to that of CSF. So the Hounsfield units are quite similar to that of CSF. Even the intensity on MRI is quite similar to that of CSF. Typically, there is no enhancement, though you may get this faint enhancement of the walls and the enhancement of the scolex, but there is no surrounding vasogenic edema. So here's a picture of pre-contrast. So this is before contrast and after contrast here. As you can see here in this image here that has pre-contrast, we can see this lesion here, this hyperdense round focus in the region of the cuneus and the precuneus area here. So you can see that there is some surrounding amount of edema surrounding this lesion over here. Then after contrast, we can see that there's this prominent ring enhancing lesion that we can see with a central dot there. So this is obviously active disease. Then in the colloidal vesicular stage, like I said, the fluid is going to become quite turbid. There may be some surrounding edema. As you can see, there's a lesion here on the left side, and with surrounding edema around the lesion on the left side. You also have sort of active lesions here on the right side. So generally the cyst and the wall actually become thickened and they brightly enhance, and the scolex can sometimes be seen, as we can see here, in the earlier colloidal phase, and is similar actually to the vesicular stage, but gradually it's going to shrink down and it's going to become quite harder to identify. Then you go to the granular stage where the edema is going to be greatly reducing, the cyst gradually is going to retract, and it's going to become a small enhancing nodule. So the cyst fluid may sometimes be demonstrated, may demonstrate this diffusion restriction in the early granular nodular stage, and disappearing during the late phase as the calcification actually is happening. And generally the enhancement is going to persist, but is less marked than the previous stage. Then the last stage is the nodular calcified, where this is the end stage, the quiescent calcified nodule. There is no edema, there is no enhancement on the CT. You get a signal dropout on the T2 sequences, and then you even get some intrinsic high T1 signals that may be present. And long-term enhancement may actually be evident on MRI and may actually even predict ongoing seizures in this patient. This is what they look like. As you can see, this person here has multiple scattered calcified nodules throughout the cerebral hemispheres. They don't have any surrounding edema. So how do we manage this patient? So if the patient just has intestinal infection without any neurologic cysticercosis, you can either give them praziquantel or niclosamide. If they do have neurological cysticercosis, it depends. You may consider just giving them corticosteroids and anti-seizure medication, or you may also consider sometimes giving them the antihelminthic agents, either albendazole or praziquantel, or sometimes albendazole and praziquantel, and you may sometimes consider surgery in some patients. So generally your aim is for you to reduce the inflammation that's going to be associated when those cysts begin to die, so when they degenerate, and you document this by your MRI to prevent any seizures in those patients that are having the seizures or those that are at high risk of seizures, especially those that have extensive disease. You also want to prevent or to relieve the increased intracranial pressure if it's present. So you generally want to consult a neurologist, an expert on neurocysticercosis, and typically you want to give your corticosteroids along with your anti-seizure medication to prevent those that are associated with seizures from having seizures and those that are high risk from developing seizures. And your antihelminthics and sometimes even surgery can be done depending on the location. For example, if you get the cysts in the fourth ventricle, you may sometimes contemplate surgery. If you get the cysts in the eye, you may sometimes contemplate surgery. For the cysts in the eye, actually, you're not even going to be treating them with the antihelminthic agents because of the risk of the effects when those cysts start to die. So generally, it's also going to depend on the size of the cysticerci, the stage of the disease, and the clinical manifestations. Generally, in terms of your corticosteroids, you want to start them before your antihelminthic agents, so roughly about 3 to 5 days. So you give prednisolone up to 60 milligrams orally, once a day, or dexamethasone 12 to 24 milligrams orally once a day, and this can help reduce the inflammation. It can help reduce the increased intracranial pressure. Remember, for your patients that are taking corticosteroids for a very long time, you want to evaluate them for any latent TB or any strongyloidosis. You want to give them some antibiotics to prevent pneumocystis pneumonia, especially if they're taking these corticosteroids for a very long time. And like I said, for those that are having at risk of developing seizures, for those that have multiple degenerating lesions, you want to put them on some anti-seizure medication, and some neurosurgical intervention may be needed for those that have increased intracranial pressure and those that have intraventricular cysticerci. In terms of the antihelminthic treatment, remember that it's quite complicated. It should be individualized, and you should consult an expert before you decide to treat. So generally, your antihelminthic therapy is not going to be quite agent. You don't need to start them now on your antihelminthic agents, because those are going to kill off the cysts and they're going to cause inflammation. So it's actually quite critical that your antihelminthic agent should be treated or should be given after you give your corticosteroids or your anti-inflammatory drugs to prevent the inflammation. The choice of treatment largely depends on the location, the number, the viability of the cysts, and even the size of the cysticerci, the stage of the disease, and the clinical manifestations. But before you actually even start this treatment, get an ophthalmological examination, consult ophthalmology, because you want to exclude any ocular cysticerci, because if you start them on treatment, you cause detrimental effects. So generally, your antihelminthic agents should not be given to those patients that have uncontrolled increased intracranial pressure, because it will keep getting worse. Then not all patients are going to be responding as well to the treatment, and not all patients actually need to be treated. For example, those that have cysts that have already died, or they are calcified, or there is potential of a vigorous inflammatory response that may worsen the disease. For example, if they have cysticercoencephalitis, when the patient is having these large number of cysts and they are widespread brain inflammation, then we may decide not to treat our patients. So when it comes to the antihelminthic treatment, it has actually been seen that albendazole is actually much more effective than the praziquantel, though most of the research has shown that if you combine the two drugs, it's much more effective for those that actually have more than 2 parenchymal cysts than anything. And there's a higher rate of radiographic resolution. So albendazole alone can be used, or in combination with praziquantel, for roughly about 30 days or more. And this has actually been shown to treat those that have the cysts in the subarachnoid space. And these tend to be actually less responsive to the antihelminthic drugs. So your patients receiving prolonged and high-dose treatment with albendazole needs to actually be monitored for bone marrow suppression and drug-related hepatitis. So do your regular FBCs, do your regular LFTs, and liver biochemistry. Your antihelminthic drugs should not lead to rapid rapid stoppage of the symptoms. So the symptoms may still be there. So you also want to manage them symptomatically. So manage the seizures, the inflammation, and the hydrocephalus. You want to do your neuroimaging every 6 months until the findings have actually resolved. So remember, before you start your treatment with your antihelminthic, give them a steroid, prednisone, or some dexamethasone. It will help reduce the inflammation that is going to be as a result of this cysts actually dying. So your corticosteroids actually do also increase the cerebral spinal fluid level of the active metabolite of albendazole, but they do decrease the CSF level of praziquantel, so they make praziquantel less effective. So methotrexate can sometimes be used as a corticosteroid-sparing agent in patients requiring more than 2 weeks of this anti-inflammatory therapy, those that have quite extensive disease. So neither your albendazole nor praziquantel should be used in a patient, like I say, that has ocular disease or someone that has spinal cord cysticerci, because of the potential side effects, because of this inflammatory response that you're going to get when the cysts are going to die. So those that have the intraventricular cysticerci, again, it's also a relative contraindication to giving them the drugs. So because of the inflammatory response that you may get, so this may result in obstructive hydrocephalus. In some patients, there is some role of surgery for those that have obstructive hydrocephalus, maybe because of this intraventricular cysticerci, including those that are in the fourth ventricle, or they have spinal or ocular cysticerci. They may need some surgery. So intraventricular cysticerci are going to be removed endoscopically whenever possible, and then shunts can also be used to reduce the intracranial pressure. So what are our general considerations of this when we put everything together? So remember, your treatment is going to be highly individualized. For those that have inactive disease, there's no need for you to treat them. For example, if it's calcified, there's no edema, just treat them symptomatically. If they're having seizures, give them anti-seizure medication to prevent that. So there is no need for the steroids, there is no need for the antihelminthic agents. But if they do have active disease, first consult the ophthalmology to make sure they do not have ocular disease. Start them on a steroid about 3 to 5 days. It can be longer if the disease is actually quite extensive. Then you're going to be adding either your praziquantel and or albendazole. So generally, if there are less than 2 cysts, you're going to prefer albendazole alone. And then generally, you can give this antiparasitics for about 14 days. Sometimes you can even go up to as far as 30 days. Then if they have some quite extensive disease, you just want to give them corticosteroids prolonged to prevent that inflammation. So remember that those that do have extensive disease do get a fundoscopy, do get a neurosurgical consult for any possible interventions. And the drug doses that we're going to be using, albendazole at 7.5 milligrams per kg orally every 12 hours for 8 to 30 days, and a maximum dose of 800 milligrams. This is the drug of choice. Alternatively, praziquantel at 20 to 33 milligrams per kg orally 3 times a day for a given for 30 days, and dexamethasone 8 milligrams IV or orally once a day for the first 2 to 4 days. These are going to be lessening your response when those worms begin to die. So remember, if your antihelminthic therapy results in the death of these organisms, the brain is going to be swelling significantly, and this is going to be attributed to those patients that have a large number of cysts and those that you start on treatment with the antihelminthic. So it's not all patients that you're actually going to be treating. In terms of prevention, remember that you're going to be preventing, this is going to be transmitted fecal-oral. So generally, you're going to be cooking your food much better. So cooking your whole cut pork to about greater than 63 degrees. As you measure with your food thermometer, you place it in the thickest part of the meat, then allowing the meat to actually rest for 3 minutes before carving or consuming. But if it's ground pork, you should cook it from greater than 71 degrees Celsius, and it doesn't need for you to rest, or doesn't need that rest period, the 3-minute rest period. You want to identify and treat those patients that are carriers of the adult Tinea solium, and it's actually quite important because this will prevent cysticercosis. And it's also quite important to teach those people that are handling food, especially in endemic areas, to practice good hand washing practices and good hygiene, personal hygiene. And when you're traveling to endemic areas with poor sanitations, you should avoid eating food that might be contaminated by human feces. So avoid eating raw foods, avoid eating uncooked foods or undercooked foods, and then also actually adequately cook your pork. These are the image attributions and resources that I used in this particular lecture. If you enjoyed this video, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.